All right, so let's take a quick break and we'll come back for lipid management. This is the pharmacology section. So we'll take a break and get recaffeinated for pharm. All right, so we're doing pharmacology for ASCVD. So what's the goal LDLs? Do you want them low or high? Get them low. How low? How low can you go? Less than 70, right? If you get the LDL less than 70, that actually stops ASCVD in its tracks. You're not going to get any further ASCVD. So that is what you want. You want it less than 70, right? Less than 190, that's good idea, but really you want to drive it all the way down to less than 90. Sorry, less than 70. All right, so less than 190 is healthy-ish, right? Greater than 190, definitely unhealthy. That's a sign of what? Dyslipidemia, dys meaning abnormal, right? So we want to decrease cholesterol production or intake. So how do you decrease intake? Well, you can stop eating cholesterol. That would help. Just like you stop smoking, stop taking cigarettes, right? But decrease production of the transport proteins. Those transport proteins being LDL. That's our trucker right there. So he's out of business. We had 220 LDL truckers. Now we're down to less than how many? Less than 70. So we are encouraging unemployment for LDLs. All right, and you want HDLs, so we're going to hire these other guys who are more wholesome, and they are like wholesome with an H, and they're going to then transport the cholesterol away from the liver, right? Sorry, away from the liver. LDLs go away from the liver. They're going to go bring all the HDLs, or HDLs are going to bring all the cholesterol from the tissues, from the cells, from the adipose, and bring it to the liver. All right, so over here you can see our HDLs. Our liver makes them. They get to choose. They decide at a certain point, hey, am I going to make HDLs or LDLs? They actually decide like at 11 o'clock at night. They have a circadian rhythm. They say, hey, it's time to make cholesterol. What am I here to make? And then they kind of survey the situation and say, hey, the cholesterol is way too high up in this biz. So they're going to say, let's make more LDLs and take the cholesterol away. Or there's not enough cholesterol here. Let's go ahead and make more HDLs so I can get the cholesterol to make more bile salts, right? Which will then make more bile salts, which are made of cholesterol. That will lower my cholesterol. And then hopefully goes to the GI tract and absorbs more cholesterol for me. But we know better, and we're going to say, I'm not going to intake cholesterol. So to fool the liver. That's our whole goal here, okay? Is to fool it into making less LDLs and more HDLs, make more bile salts so that we can't absorb, and then also, diet-wise, not absorb cholesterol, okay? So diet-wise, that's going to help. That's a non-pharmacological way to fix it, right? Diet and exercise, if we can do the ABCDE, that's going to be the recommendation, but it fails, unfortunately, especially in America, where we have easy access to calories and cholesterol calories. And exercise, what does exercise actually do? It actually increases LDL breakdown. It literally goes in there and it breaks down LDL. It's going to, it doesn't like stop the liver from making it. It just goes in and just annihilates it, right? So it stops the LDLs, and the VLDLs are the precursors. And if you break down all of these LDLs, it's going to then increase HDL production. All right, so all these LDLs out here in the periphery are collecting cholesterol, and they're bringing it back to the liver. So what does exercise do? It just eliminates it on the way. It's like, oh, I see you're driving there, and done. Right? They like slash tires on the LDL. All right, so then pharmacological. So we have two kind of big classes of pharmacological agents to either reduce the production of LDL, or reduce cholesterol production, and that of course will reduce LDLs and cholesterols overall. And we have other agents that will inhibit the absorption of cholesterol. So they decrease the intake of cholesterol into the body. So they stop the gut from absorbing it, or they stop the bile salts from being made so that they can't absorb the cholesterol, right? Because to absorb cholesterol in the gut here, right? In the gut, so here's the brush border of the gut. We have the lining of the gut, the little villi there that suck up cholesterol, right, into our lymph system. And if we just stop them from absorbing, then you're not going to get cholesterol in your diet. So we have specific medications like ezetimibe, which is an agent that inhibits cholesterol absorption, right? But our number one agent, like above all the rest, it's the most effective, is statins. So statins are number one. So everybody's on a statin. In America, everyone's on a statin as well, right? So statins are there they actually just abruptly stop the production of cholesterol, right? And total cholesterol is a sum of our LDLs, VLDLs, and HDLs. So it reduces your LDL count. All right, statins all end in statins, which is nice, right? And we just call them statins, but that's not technically their category. Their category is HMG-CoA reductase inhibitors. Those are just statins. And the only reason to bring that up is like the mnemonic for the side effects is HMG-CoA, sort of, right? So H for hepatotoxic. You imagine if it works in the liver, I guess I can't come this way anymore. All right, if it works in the liver, then no, it's not fine. I'll wait over here for 30, 45 minutes. So HMG, H stands for hepatotoxic. So if it's working in the liver, it's going to damage the liver potentially. So it's hepatotoxic. So you got to make sure your liver's not dying. Your liver has enzymes inside of its cells, and when the liver cells die, they release their enzymes. Which important enzymes can you measure to see if someone has hepatotoxicity? AST and ALT. All right, what does it stand for? Extra credit. All right, not today. All right, AST and ALT. So those are things we need to check routinely. Every 3 months or so, we can check AST, ALT, all right, and make sure that it is not going up or down. Up, right? So when cells die, they release their cell contents. And in the liver, those cell contents are AST and ALT. So what else? So AST, ALT for H, and then M for myopathy. So the muscles die. So our muscles can die to the point of rhabdomyolysis, which is the R there. So myopathy meaning that just their muscles hurt and their muscles are achy, and then their muscles and tendons can just spontaneously rupture one day. That's a cool thing to live with. Your tendons might rupture one day. Continue taking this medication, but also that's a little hard sell. But they can just rupture, spontaneously pops, and then you're out of business for 6 weeks, right? Or your muscles can just start breaking down all of a sudden, all your muscles, and then that's causing the contents of your muscles to spill. Right, so we can measure what's called CK, creatine kinase, which is inside of our muscles, all right, and that can spill out. And so with our 3-month checkup, we should be checking the CK and the AST, ALT. And then it causes diabetes. That's not good. So it causes diabetes, so check the A1C, make sure that's going the right direction. I'm taking care of myself. What's going on? Well, it could be this medication here that's causing it. It also damages your eyes. You go blind, your liver fails, and your diabetes acts up. So, but it's the most effective. Or you could do this, or you could do diet and exercise. It's up to you, right? Either one. But after 3 months, your lipids are not going the right direction. We don't want you to die, and your family doesn't want you to die. So let's start you on this statin, right? And they can then do diet and exercise, and hopefully in the 3 months later, things are going the right direction. They can trial off of it. So our goal, of course, is to get people off medications. But if they need it, they need it. Okay. And then what else? So increased DM risk. So that's kind of the reason why I bring up HMG-CoA reductase inhibitors, because the mnemonic is there somewhat. All right. And then we have our cholesterol absorption inhibitors, and we have the next 2 slides after this go into detail about how these work and such. But cholesterol absorption, there's only one of them. It's called ezetimibe. It's going to inhibit the absorption of cholesterol and triglycerides a little bit. And then we have bile sequestrants. So sequester is just a fancy word for hold on to. So it like binds to the bile and stops it from being produced. So it works kind of up here and it stops, where's it at? Ezetimibe works up there too. The bile acid sequestrants, they're going to stop the absorption of cholesterol as well. All right. We have niacin and our fibrates. Those guys can be used also to stop production of cholesterol and stop the release of triglycerides and free fatty acids from the adipose. We'll talk about those in more detail. And our new guy on the market for like the last 10 years or so is a sub-Q shot. It's a sub-Q shot designed to stop LDLs. Right? It's going to lower your LDLs. It's going to stop it's an inhibitor. So usually we have this little protein here, which is going to break down LDL receptors. And LDL receptors we don't want, LDL receptors are going to be there that when you have more LDL receptors, more LDL can attach to it, and then you can get rid of LDLs. So this will stop that process. All right, so then we'll go into each one of these guys. So statins, a whole slide on statins. So they have to take these lifelong. All right, they can try to transition off of them, but if they aren't going the right direction, they should need to be on them pretty much for life. And you can see there in red, the top middle, that is the earlier you started, the better off you are. right? Diet and exercise, we will try, but really if you have risk factors, you have a stroke, you have a PAD, you have different things, it's like, okay, now I'll take the statin. You actually have a worse chance, you have a better chance of dying if you don't take it early. So you want to make sure that, that's an important conversation they have to have. It's like, hey, yes, I want you to diet and exercise, but it didn't work. So let's go ahead and try the statins because you have diabetes, you have CAD, you had a heart attack as well, and you had a stroke. So really we need to get these statins on board. Okay, so HMG-CoA, that's what makes cholesterol. So if we stop that, so HMG-CoA makes cholesterol, and then LDLs will then take that and go with it. They'll take the cholesterol, form itself into LDLs, and it will then take that cholesterol out to the periphery, right? So we give HMG-CoA reductase inhibitors. They're going to stop that whole process. I did purple. There we go. It's going to stop the whole process from happening. So this decreases your total cholesterol and decreases your LDLs. So what does the liver think? It's like, well, shoot, where's all my cholesterol at? I need to make more I need cholesterol from the periphery. I'm short on cholesterol. So it hires more HDL truck drivers, and the HDL is going to then bring the cholesterol back to the liver, and then it's going to then convert that cholesterol, which will lower your cholesterol, into bile acids to hopefully absorb more cholesterol from the gut. Little does it know you're on this medication, which is kind of going to grease the wheels. All right. So what else? So side effects. We talked about HMG, the mnemonic there. That can work for you, or you just remember those 5 things or so. Those things are important side effects. They happen a lot. So we want to, it's not like just, GI upsets. Yes, that's for every medication, but it can be really difficult to tolerate it for the first couple months. It kind of goes away after a while. But muscle damage is not good, and liver damage is not good. So your tendons can literally rupture. So this lady right here down middle, she has her tendon, her Achilles tendon just pops. You can see the muscle move as she lands right there. And it sounds extremely loud. When your Achilles tendon pops, it's a loud event.
This is the loud sound a tendon makes when it snaps. This person caught an Achilles tendon rupture on video, so listen closely. There it is. Follow for part 2 and I'll...
So yeah, that's the risk of statins. It can also damage your liver, cause diabetes, and cause your muscles to break down, and also cause your tendons to rupture. So it's like you can do that or diet exercise, but I'm exercising. But yeah, okay. So that's a important consideration. So statins are involved in preventing cholesterol production. So fat absorption inhibitors, these guys inhibit fat absorption, cholesterol absorption in the gut. So usually in the gut, we have bile acids, and the bile acids emulsify. So like mayonnaise is emulsified, whereas vinaigrette is not, right? Vinaigrette is harder to absorb compared to mayonnaise. That's easy to absorb, right? It's already been emulsified for us. So we can take cholesterol, bile acid is going to emulsify it for us, emulsify whatever fats we intake, and it's going to get reabsorbed, right? All our triglycerides, cholesterol gets absorbed, and that then gets formed into LDLs and such, and that's going to be bad. So what if we inhibit the bile acids? Well, now we can't absorb cholesterol, so that's good. So we inhibit the bile acids, and your liver's like, where's my bile acids at? I'm going to make more bile acids. So it makes more bile acids out of the cholesterol you already have. Okay, so cholesterol absorption inhibitors versus bile acid sequestrants. So bile acid sequestrants are going to sequester, bind to the bile itself, and it's going to then, if the bile is ineffective, that bile cannot get reabsorbed because your body's always reabsorbing things. 95% of the bile acids you make get reabsorbed for next time, for the next meal. So what if you just interrupt that process and stop the absorption of bile acids? Well, now you have to make more bile acids, and therefore you have to use more cholesterol that you already have. Okay, so that's the idea with bile acid sequestrants, and it's going to cause some GI upset because it's working right there in the GI tract. It's really, that's the spot it's working. Going back to cholesterol inhibitors, there's only one of them called ezetimibe. Ezetimibe is working right here on that brush border of the GI tract. There's a little villi. It's stopping them from absorbing cholesterol. All right, so cholesterol gets absorbed, stops getting absorbed here. Our cholesterol levels go down. And then if cholesterol levels go down, your body's like, what the heck, where's all my cholesterol at? It's going to then convert cholesterol you do have into bile acids to absorb more cholesterol, but ezetimibe, it's right there, it's going to stop the absorption, right? So the whole goal here is lowering our fats. And then, of course, we don't get fats absorbed especially with ezetimibe. So the fats don't get absorbed. It's not like osmotically active, but it's greasy. And it's greasy and it's going to come out greasy. People complain of anal leakage of grease. And then it kind of makes your stools float. And the fancy word for that is called steatorrhea. And it's causing significant diarrhea as well. So the steatorrhea on a scale of 1 to 10 is like an 11 as far as smelliness and stinkiness. So if you've ever had the pleasure of cleaning up a GI bleed, that's probably like an 8. So this is like an 11. It's extremely stinky, extremely greasy. It floats. So does it sink? No, it floats. That used to be a popular game show. All right. So does it sink? So someone on ezetimibe, they would have steatorrhea. And steatorrhea, there's all kinds of different disease processes that might cause steatorrhea. I think next semester we talk about a few more of those. But right now, this guy is the one that causes steatorrhea, causes fatty diarrhea. The fattiest, floatiest, foulest farts you ever did see. All right, so what else on ezetimibe? So ezetimibe and our bile acid sequestrants are no fat. You are not absorbing fat with these guys. And then other non-GI agents. These aren't working on the GI tract. They're not really working very much on the liver. So niacin is working on the fats, and they're stopping the fats from breaking down, from providing cholesterol. So your liver's like, what the heck? Where's my cholesterol at? Niacin's there stopping the cholesterol from getting used. So it produces more HDLs in response to take the cholesterol out from the periphery. Niacin also blocks HDL receptors on the liver, tricking it, saying, hey, you don't have any HDLs, so then it makes more HDLs. The other thing with niacin is it causes significant flushing. That's like he's like, I take this medication all the time, but I get flushed and warm. I don't like it. So they should be taking aspirin at the same time. So that's a key medication that is always taken with aspirin also. They probably already are on aspirin because they might have an ASCVD event, right? Or ASCVD risk factors. But aspirin is important to take with it so it doesn't cause this flushing side effect. And we have fibrates. So fibrates all have fiber in the name, which is nice. You would think fibrates work in the GI tract. Unfortunately, they don't. They like you eat fiber, and fiber absorbs your cholesterol, and then like Cheerios may lower cholesterol, but it doesn't. So it's like well, may lower cholesterol, does it or doesn't, right? I'm sure there's some science out there, right? But we want to make sure. When we think of fiber, we think of stopping cholesterol absorption in the GI tract, but it doesn't do that, right? It actually breaks down the LDLs in the circulation. It actually tells the liver to break down free fatty acids as well. The free fatty acids are what make up triglycerides. Triglycerides are 3 fatty acids, triglyceride, and one glycerol and 3 fatty acids. So it breaks down the fatty acids so that you don't have cholesterol to make. All right, and triglycerides to make. This also causes muscle damage. So just like which other medication? Statins. So those are the 2 medications that break down our muscles. So we should be checking what? Muscle breakdown enzymes, which are CK or creatine kinase. All right. Our last medication is a PCSK9 inhibitor. So what does PCSK9 do? It takes LDL and LDL receptors, and it abducts them. If you have an LDL receptor, the LDL will bind to it, and then the LDL will then get processed away, right? And then the LDL receptor will get recycled back to the surface of the liver for another LDL. So having LDL receptors is good because it's going to get rid of LDLs. What does PCSK9 do? It stops that from happening. It's going to abduct that receptor and also LDL that might be on it. It's going to take all that away so that the liver does not recycle into more LDL receptors. So we do give a PCSK9 inhibitor. There's only one of them, evolocumab. And when you ever see MAB, unfortunately, MABs are designed by like the 10 people that designed the drug. They say, hey, you designed it, Evan, all right, and then Lewis, okay, and you got Kevin with a C. So they put all their names together, and there's like no rhyme or reason about how it like beta blockers are all LOLs, right? There's no way to say that this monoclonal antibody is for asthma, or this monoclonal antibody is for the liver, or this monoclonal antibody is for autoimmune stuff. That's unfortunate. Then like in 2021, people finally got upset. They say, you guys are out of control. You guys need to have some kind of naming convention so we know what each one of these syllables mean. So when we come back to asthma, we're going to get some more of those MABs, unfortunately. And It's just really memorization as far as maps are concerned. And like the cancer guys and oncologists, they got away with this. There's a lot of medications out there that have, yes, they all end in mAbs. You know, it's a monoclonal antibody, but it's really hard to figure out like, oh, this one's for that and this one's for that, right? So what is a monoclonal antibody? It's something that's designed in the lab. It's brewed by bacteria or brewed in a test tube, and it's a little antibody. Antibodies, what do antibodies do? They fight infection because they float around in the bloodstream. They are bodies that float, like celestial bodies. They float around, and they are specifically designed for one specific thing, right? One specific license plate or an antigen, right? Like infection, you have an antigen on a MRSA, right? Bacteria, you form antibodies against it, and you attack it, right? So this will attack specific things that you brewed in the lab. What are we attacking? PCSK9. So that's where we're getting that out. We're taking it out of the equation. Like when we talk about asthma, it's taking away some of the inflammatory mediators. It's blocking these interleukins and those inflammatory things. Okay, so these are other non-GI agents.